of muscle fiber degeneration and regeneration on biopsy. Weakness is usually evident at birth, or sometimes it have late onset. What is term dystrophin means? It means abnormal growth. Basically, it's a protein, it's abnormal growth, and its destruction may lead to muscular dystrophies. The disorders are due to mutations in genes that are involved in making muscle proteins. Like in Duchenne and Becker, there's problem in dystrophin gene. Clinically, they are subdivided by the mode of inheritance, age at onset, distribution of involved muscles, rate of progression, and long-term outlook. The disorders may be X-linked recessive disorders. The most common disorders like Duchenne and Becker's, they are X-linked recessive disorders, and they may be autosomal recessive or autosomal dominant. Again, the most common type is Duchenne muscular dystrophy that we will discuss later on. So what are important or generalized symptoms associated with muscular dystrophies? Because the disorder of muscles, so muscle weakness is the most important symptom and sign on examination. Patient may have delayed development of muscle motor skills. For example, patient may start walking late. They have difficulty walking, delayed walking, difficulty using one or more muscle groups depending on the type of dystrophy. Patient in some muscular dystrophies may have the weakness of eyelid muscles causing eyelid drooping or ptosis. For example, FACIOSCAPULOHUMERAL dystrophy, drooling, hypotonia. Some muscular dystrophies, especially congenital muscular dystrophies, may be associated with mental retardation. Joint contractures, clubfoot, claw hand, or others, sometimes they may be the early presenting features. For example, in EMERY-DREIFUSS muscular dystrophy, scoliosis, lordosis. So these are all the symptoms and signs associated with muscular dystrophies. Examination will reveal, and especially examination and history help to distinguish the types of muscular dystrophy. Specific muscle groups affected by different types of muscular dystrophy. Often there is a loss of muscle mass, very common finding in all muscular dystrophies, which may be disguised in some types of muscular dystrophies by an accumulation of fat and connective tissue, which makes the muscle appear larger, pseudohypertrophy. You may find on examination that patient may have a bulky muscle, but actually it is what fat and connective tissue that replaces the normal muscle tissue, and it causes a type of a hypertrophy that is called pseudohypertrophy. Joint contractures are common. Shortening of the muscle fibers of the connective tissue and scarring slowly destroy muscle function. Some types of muscular dystrophy involve the heart. Especially major muscular dystrophies like Becker's, Duchenne, EMERY-DREIFUSS, and myotonic dystrophies, they involve the heart. And they can cause cardiomyopathy or arrhythmias. Sometimes patients have to be prophylactically put on cardio pacemakers to avoid cardiac failure and damage in these muscular dystrophies. Muscle biopsy is basically the gold standard for diagnosing muscle problem with muscular dystrophies. Sometimes, or in many cases, DNA from the blood may be sufficient to diagnose the muscular dystrophy. Very important clinical sign, and many times asked in your exams also. What is Gower sign? Basically, Gower sign, the patient uses his hands to rise from sitting position. That is called Gower sign, as you can see in the picture here. Because of the weakness of the muscles in hip joints or in hip girdle, this is probably Becker muscular dystrophy, Duchenne muscular dystrophy. Child uses his hands to rise up from the sitting position, as you can see here. This is due to weakness in the limb-girdle muscles, proximal weakness. So classification on the basis of genetic inheritance is X-linked. The most common type that include Duchenne and Becker muscular dystrophies, EMERY-DREIFUSS. It can also be autosomal inheritance also. Autosomal recessive muscular dystrophies with congenital muscular dystrophy, limb-girdle muscular dystrophy, and autosomal dominant muscular dystrophies like limb-girdle muscular dystrophy, FACIOSCAPULOHUMERAL muscular dystrophies. These X-linked muscular dystrophies are very common, especially these two, Duchenne and Becker muscular dystrophies. This is a picture just to get you an idea of which muscle groups are affected in which type of muscle dystrophies. As you can see here, Duchenne and Becker types, the muscles involved are muscles of the shoulder girdle and the hip girdle along with peroneal muscles. While in case of Emery-Dreyfus, the upper muscles of shoulder girdle, pectoralis muscle, and in the lower limbs only distal muscles are affected, these peroneal muscles. This is purely a limb girdle type muscular dystrophy in which only limb girdle muscles are affected, shoulder girdle and hip girdle. This is, as you can see, facial muscles are also involved along with scapulohumeral muscle groups, and in lower limbs distal muscles like peroneal muscles. So this is facioscapulohumeral type. When ocular muscles are also involved, it is called oculopharyngeal type. Important features of different types of important muscular dystrophies as I showed in the picture. So this is the same description of the picture. You can see in Becker and Duchenne very important and common muscular dystrophies, weakness of muscle occurs in males only because it's X-linked disorder. Becker is slightly less severe and usually it is late start, but Duchenne appears early and is a very fast progression. So to start with Duchenne's muscular dystrophy, it is an X-linked neuromuscular disease which is characterized by rapidly progressive muscle weakness and wasting. Duchenne muscular dystrophy is caused by absence of dystrophin that affects primarily boys, but in rare cases it can affect girls as well. In rare cases. In majority of cases or in most cases it is X-linked disorder. You can see the child disabled and on supportive management. Most cases and most common type of muscular dystrophy. So 2 important points, it is the most severe and most common disorder of muscular dystrophies. Death in this type of muscular dystrophy usually occurs by the age of 20. So pathophysiology is basically defective dystrophin, which is located, what is normal dystrophin? It is located on the cytoplasmic face of the plasma membrane of muscle fibers, which serves as a component of large, tightly associated glycoprotein complex. It provides basically mechanical reinforcement of the sarcolemma and stabilizes the glycoprotein complex, leading to its protection and shielding it from degradation. So defective dystrophin will lead to degradation of muscle fibers. Here you can see the difference of dystrophin gene associated with mutation in Becker and Duchenne muscular dystrophy. Here you can see the normal reading frame and the sequences on the normal gene, but in case of Becker muscular dystrophy, this is a large deletion that occurs, but the reading frame of the DNA is intact. While in case of Duchenne, which is very severe type, the deletion is actually small, as you can see here. But reading frame of the DNA is damaged or changed, so it doesn't produce dystrophin. While in case of Becker, dystrophin is produced, but it's not so insufficient amount, or it is, you can say, a defective dystrophin. So that's why Becker is mild form of disease, while this Duchenne is severe form of disease. Children with Duchenne muscular dystrophy are often late walkers. They may have intellectual disabilities and learning difficulties. They may lose the ability to walk by the age of 7 to 12 years. What is clinical manifestation of Duchenne muscular dystrophy? Because Duchenne muscular dystrophy is the most important muscular dystrophy, so we will discuss in some detail. Otherwise, you do not need to go in detail of other muscular dystrophies. Early manifestations include patient may be clumsy and may fall frequently. It may have difficulty in jumping or running, and you may see there are enlarged calf muscles in patients with Duchenne muscular dystrophy. Actually, it is feet and fibrosis. It is not active muscle tissue, and patient may have early contractures. In transitional phase, trunk weakness may also occur. Like here, you can see this is trunk weakness, and muscle weakness become more prominent. What is pseudohypertrophy? As I discussed before, as you can see here, calf muscles, normal muscle tissue is replaced by fatty tissue and connective tissue. It is actually not muscle tissue, and you will find it on needle examination or in sometimes electromyography that there's no such muscle activity when you insert needle here. In later stages, loss of ambulation occur around 10 to 14 years of age, in which most patients use wheelchair, and scoliosis may also develop. Basically, in scoliosis, what occurs? Lateral curvature of spine becomes prominent. Children they walk on their toes or the balls of the feet with a slight waddling gait. So this is a depiction of the associated problems in Duchenne muscular dystrophy in later stages. In later stage, you can say in 15 plus, there are life-threatening heart and respiratory problems because of involvement of respiratory muscles and cardiac muscles. What is treatment? Basically, physical treatment, rehabilitation is the mainstay of treatment. Long-term medications, especially corticosteroid therapies, are sometimes prednisolone is given initially to slow the progression of the disease. Otherwise, it is not curative treatment in case of muscular dystrophies. What is Becker muscular dystrophy? It is also X-linked disorder, and it's the same fundamental disease as Duchenne muscular dystrophy, as I discussed before and show you in the picture. So genetic defect is same as dystrophic in Duchenne muscular dystrophy, involving dystrophin gene at X chromosome 21. Mutations preserve the reading frame, as I discussed and showed you in the picture, and still permit translation of coding sequences, but produces semi-functional or dysfunctional dystrophin. So clinical manifestations are similar to Duchenne muscular dystrophy, but milder and slow, protracted course. The weakness usually starts later than Duchenne muscular dystrophies. Boys usually remain ambulatory until late adolescence or until early adult life. Calf pseudohypertrophy, cardiomyopathy, elevated serum CK levels are similar with Duchenne muscular dystrophy. So this has same clinical features as in Duchenne muscular dystrophy, only the age difference is here and the slow progression of the disease is here. And patient may have same calf pseudohypertrophy, cardiomyopathy. Serum CK level are very important in both Duchenne and in Becker muscular dystrophies. They are highly raised in these muscular dystrophies, highly raised in case of Duchenne dystrophy. You can say more than 50 to 100 times, while they are also highly raised in case of this Becker muscular dystrophy. It should be more than 10 times normal initially in the disease. But learning disabilities are less frequent in case of Becker than in case of Duchenne. Death often occurs in the mid to late 20s. Fewer than half of the patients are still alive by the age of 40 years. However, these survivors are usually very severely disabled. So what are important differential points between Duchenne and Becker muscular dystrophy, both X-linked muscular dystrophies, both affecting males. So age in Duchenne is early, 2 to 5 years, while it is late, 8 to 10 years in Becker. More common, Duchenne, as I discussed, it is less common, Becker. Progression is rapid in case of Duchenne muscular dystrophy, while it is slow in case of Becker muscular dystrophy. Intelligence is subnormal in case of Duchenne, it is normal in case of Becker. Life expectancy 15 to 20 years, 25 to 30 years. Cardiomyopathy is very common in case of Duchenne, but is rare in case of Becker muscular dystrophy. In investigations, if you see dystrophin levels, it is markedly reduced, this dystrophin gene or dystrophin protein in case of Duchenne, but it is reduced in case of Becker muscular dystrophy. Contractures are early. There are no early contractures in Becker. Associated problems, cardiomyopathy, but color blindness is found to be an important differential in Becker than in Duchenne. Patient means ambulatory up to 9 to 11 years, and while in case of Becker, it is 15 to 20 years. Prognosis is severe in case of Duchenne, death by 16 to 20 years, less severe, benign course of illness, death in the 4th or 5th decades. So Duchenne and Becker muscular dystrophy is a very important topic, and you must know about these in details. And these are other rare muscular dystrophies that I will briefly discuss. Emery-Dreifuss muscular dystrophy is also basically an X-linked recessive disorder, but it can be autosomal dominant inheritance. Usually the onset of the illness is in 5 to 15 years of age, and the most important thing to remember in these dystrophies is that there is early development of contractures of elbows and knees, early contracture development, important differential and diagnostic clinical point in case of Emery-Dreifuss muscular dystrophy. As I discussed, these scapulohumeral peroneal muscle wasting occurs. Scapulohumeral and peroneal, in lower limb, these distal muscle groups are affected, not proximal, but in upper limb, this proximal muscle group is affected. Patients have normal intellectual functions, but they are having some very severe cardiac dysfunctions and cardiomyopathy and cardiac arrhythmias, and in majority of cases you have to insert prophylactic pacemakers in these patients because it is long-term management of patients with Emery-Dreifuss muscular dystrophies. Hypertrophy of muscles, facial weakness, myotonia may occur, but it's less pronounced, and serum CK level is not so much or so severely elevated as case of Duchenne and Becker. Muscle biopsy will show the characteristic findings on Emery-Dreifuss muscular dystrophies. It is slow progression, and most patients survive to late adulthood. Management, as I said, is supportive, and special attention to cardiac conduction effects, for which you prophylactically use pacemakers. Limb-girdle muscular dystrophy is which one? It is basically autosomal inheritance. It may be recessive and it may be dominant inheritance. Onset is before, middle, or late childhood. Affects muscles of hip and shoulder girdle. That's why it's called limb-girdle muscular dystrophy. Upper limb muscles around shoulder and girdle are affected, and lower limb muscles around hip girdle are affected. Hypertrophy of the calves in ankles may occur. Patient may have lordotic posture. Patient may have weakness of flexors and extensors, and sometimes diminished deep tendon reflexes. Serum CK level again elevated in case of limb girdle, but not so much pronounced as in case of Duchenne and Becker. EMG and muscle biopsy may show evidence of muscular dystrophy, but less specific. ECG may show findings, and it may be normal. Rate of progression varies, usually confined to wheelchair by the age of 30 years. FACIOSCAPULOHUMERAL dystrophy, only the difference you will see here, the facial muscles are also involved in this case of muscular dystrophy, along with muscles of shoulder girdle, facial muscles, and peroneal muscles. Onset is again before, middle, or late childhood. Affect muscles of facial and shoulder girdle. As you can see here, pharyngeal and tongue muscles are also involved in case of FACIOSCAPULOHUMERAL dystrophy. Scapular winging, you may find Gowers sign positive in these patients. Serum CK level again in these kinds of FACIOSCAPULOHUMERAL dystrophy may be greatly elevated. EMG is not specific, and it may show only myopathic muscle potentials, and this EMG finding is consistent with all myopathies of muscular dystrophies. It is not diagnostic test, but it shows the myopathic uh, nature of the disease, as well as to differentiate it from other disorders like neuropathic weakness and other plexopathic weakness or some other disorders. EMG is very helpful initial test in all muscular dystrophies. Sorry. So prognosis in these cases may be, it may show mild disease that leads to minimal disability, and it's not so rapidly progressive disease, and patient may survive with normal life but with some weakness of these muscles. Myotonic dystrophy. After Baker and Duchenne, this is most important dystrophy to be discussed because it is the most common type of muscular dystrophy in adults. Not in childhood group, but in adults, this is the most common type of muscular dystrophy. It is also called dystrophia myotonica. There are two types, myotonic dystrophy type 1 and myotonic dystrophy type 2. Clinical features, you will see hedged-faced patients, means there will be vesting of temporalis, masseter, and facial muscles. Frontal baldness is very characteristic of these myotonic dystrophies. Neck muscles, including flexors and sternocleidomastoids and distal limb muscles, are also involved early. Very important thing to remember in these myotonic dystrophies, and as they occur in adults, that their proximal muscles are spared throughout the disease course, and distal limb muscles are more affected. Here you can see the picture of myotonic dystrophy patients with frontal balding, and this hatchet facies is due to basically this vesting of the temporalis and masseter muscles and other muscles of facial expression that may cause ptosis and drooping of the mouth. Vesting of the sternocleidomastoid may be present. Other systemic features, you will see that cataracts may be found in these patients. Gynecomastia leading to hypogonadism may be seen in these patients. This is a list of investigation that you can order in patients with muscular dystrophies. It is general list, so we will discuss briefly that muscle biopsy is very basically the gold standard and the primary test used to confirm the diagnosis. You can see the changes in the muscles, or you can order the DNA test, which is more confirmatory and specific for all the muscular dystrophies, and to see the genetic defect. So DNA test is more important, and if you order it from muscle biopsy or from blood. Serum CPK level is very supportive test because it may be highly elevated in cases of most common muscular dystrophies like Baker and Duchenne muscular dystrophy. Electromyography, as I discussed, is very important test in case of muscular dystrophies and in case of all myopathies because it helps you to differentiate a muscle disorder from the more proximal disorders like neuromuscular junction disorders, for example, myasthenia gravis, or from neuropathies. Weakness can also occur in neuromuscular junction disorders as well as in neuropathies. So this is EMG that shows you that the problem is in muscles. It is not in neuromuscular junction. It is not in in the nerve, peripheral nerves, and it may show you that the patient is having myopathic potentials. ECG in all muscular dystrophies should be ordered. Electrocardiography, it may show you changes in cardiac status, and it may show cardiac arrhythmias and myopathic potentials, cardiomyopathic changes. Patient must be looked for myoglobinuria, and you know when muscle is damaged, the myoglobin is released into bloodstream, so it is filtered out of the bloodstream by the kidneys and eliminates in the urines. In larger quantities, myoglobin can damage the kidney and break down into toxic compounds causing kidney failure. So myoglobin from urine and serum should also be checked for in patients with muscular dystrophies. LDH is basically used to evaluate the presence of tissue damage. It is not specific for muscles, but it is non-specific, and it shows elevation of the LDH just shows that there is tissue damage. It can be muscle tissue, it can be heart tissue, it can be liver or kidney tissue, or even brain and blood cells. Creatinine. What is creatinine that we usually order in baseline investigations? Urea and creatinine. Basically, it is a function of the status of the kidneys, but creatinine is a breakdown product of creatine, which is an important constituent of muscles. A serum creatinine test measures the amount of creatinine in the blood. If they are greater than normal levels, it may indicate that patient may have some kidney problem, or patient may have some muscular problem like muscular dystrophy. Lower than normal levels also indicate that there are some muscle problems because muscles are so dystrophied and atrophied that it doesn't produce creatine. In late stages, you may have lower than normal creatinine. AST is again not very specific. It may be increased uh, in many conditions and also in progressive muscular dystrophies. Aldol is also indicator, raised aldolase is also indicator of muscle damage. There's no curative treatment still or yet for muscular dystrophies. Medications and therapies can relieve symptoms and they can slow progression of the disease, but they cannot cure the disease. But you must know that in genetic engineering or in genetic research continuing throughout the world, this is the hot topic. Muscular dystrophy, especially Becker and Duchenne muscular dystrophy, and its genetic modification process and its curative treatment. This is hot topic nowadays, and the researchers are trying to see the ways how to insert a working dystrophin gene into muscles of boys with Duchenne and Becker muscular dystrophy. I hope in a decade or in maybe in 5 to 10 years, we may find very curative and specific treatment for these dystrophies. Also, researchers are exploring potential muscle building drugs to help reverse progression because there is wasting in these disorders. So, they are researching on drugs that can build up the muscle mass. Dietary supplements like creatinine and glutamine are some potential treatments that are under investigation. Medications that we use in our departments or in neurology, corticosteroids or steroids are used in the most common form of muscular dystrophy and the most severe form of muscular dystrophy, like Duchenne muscular dystrophy, and sometimes in Becker as well, because they can slow the progression of the damage in patients with these dystrophies. Phenytoin, procainamide, or quinine, antiarrhythmic drug, basically they are used to treat delayed muscle relaxation for those with myotonic dystrophy, myotonic muscular dystrophy, because myotonia is a prominent feature in myotonic muscular dystrophy and it is troublesome for patients. So these antiarrhythmic drugs called, the most important among them is phenytoin, which is commonly used to treat the muscle problem associated with myotonic muscular dystrophy. Medications can also be prescribed to treat heart problem in some forms of muscular dystrophy, and many studies are being conducted to find additional treatment methods. Along with medications for heart problem, pacemakers are also implanted, for example, in case of EMERY-DREIFUSS and in case of other muscular dystrophy like myotonic dystrophy. These pacemakers are prophylactically implanted. Mainstay of treatment, physical therapy, rehabilitation. You can see that braces, wheelchairs, and canes, they can improve mobility. Sometimes surgeries performed on the spine or legs, and it will relieve the malfunction in the joints. Exercise. People suffering from muscular dystrophy should be as active as possible, and physical inactivity may make the disease worse in case of muscular dystrophies or in case of any muscle problem. What are the benefits of exercise? Primary focus is on gaining muscle strength because muscle is already weak. So if you make patient not having exercise, it will further decrease muscle function and endurance. Aerobic exercise is important in preventing excess body fat as well as decreasing cardiovascular risk factors. Stretching increases range of motion and it prevents contractures. For children, exercise activities should be as game-like as possible. Thank you very much. Kindly you can post your queries about this topic. I will be happy to answer you as soon as possible for me.